Good afternoon. I am Dr. Amitava Sen Gupta and I am Director of the Mother and Child Unit, Neonatology and Pediatrics at Paras Hospitals, Gurgaon, NCR, India. Well, a very important and interesting thing about the neonate as well as the fetus, wherein we discuss the change in environment while the baby is in the mother's womb and right after it is born, and if sick gets transferred into the NICU. While the baby is in the mother's womb, it is in a very conducive environment with less exposure to sound and light, in the later stages in a flexed posture, in warmth, in fluid, and with a constant connection with the mother, who is able to hear the mother's voice, heartbeat, and has a chemosensory connection. From this very comfortable environment, if a baby is born preterm, he has not been in flexion but maybe in extension posture in the preterm babies, gets into the NICU, which is a very alarming and frightening environment for him or her, with lot of sound, lot of light, infliction of pain through procedures, intravenous lines, central lines, intubations, and of course not having proper positioning or handling in the normal neurological modality. Well, at our unit at Paras, this is a tertiary care level 3 unit, we have a wide variety of kids coming in outborn as well as inborn. So everybody knows about the preterm babies, who are the small low birth weight or very low birth weight or extremely low birth weight, that is below 1000 grams, and the preterms, which is basically below 28 weeks, is extremely preterm, 28 to 32 is very preterm, 32 to 34 is moderate preterm, and 34 plus to 36 and 6 days is late preterm. So we have the preemies, the ELBWs, and also along with this we have term babies who have other illnesses which could be associated to respiratory, cardiac, or anything in critical forms, and also congenital anomalies which do come across. The other challenges are the outborn babies who are sick but are transferred in, and during the transport they are destabilized, and we receive them in a possibly compromised state. So this is a wide variety of surgical as well as neonatal medicine cases which we do get in our unit, and we try to tackle to the best of our ability. In today's scenario, we may be tackling as sick babies as possible and the tiny 800 grammers, but the gold standard today is intact survival. We want a good neurodevelopmental outcome of these preterm, fragile, or critically ill newborns, and hence intact survival, growing up to be a good normal child and a good adult, productive and of use to the country, is what our aim should be. In order to achieve this, NICUs should have a program of developmental supportive care in place while the sick babies are in the NICU for 2 weeks, 15 days, 3 weeks, 4 weeks, or 6 weeks, or whatever be it. Now, as I had mentioned about the developmental supportive program, the DSC program is in the NICU. This is a broad group of evidence-based interventions which help and promote the good neuromotor maturation by decreasing the stress and pain of the neonates and concentrating on proper positioning, handling, and other modalities which would cause good neuromotor behavior. Now, to just elaborate or maybe just tell you the structure, there are 5 core measures of developmental supportive care. Number 1 is protected sleep, which is the most cardinal one, which is deep, uninterrupted physiological sleep of the preterm baby, which promotes optimal brain growth and weight gain. Number 2 is assessment and management of stress and pain in the NICU for the baby. Number 3, activities of daily living, which means doing all the activities of diaper change, positioning, handling at one time rather than disturbing the baby again and again. Number 4 is family centered care, wherein we have the family in tandem with the neonatal team looking after the baby within the NICU. I think we have covered 4. And the 5th is a healing environment where we look after the important issues like the behavior of the neonatal staff towards the baby, the sound levels, light levels, and monitoring the same. See, now NICUs can be tertiary care state of art, but it is a most important issue that we should understand that loud sound is harmful for the preterm baby. And at the infant bed area, we should have permissible 45 to 50 decibels, and in the areas where the sisters and doctors are writing and carrying out their notes, etc., should be permitted up to 55 decibels or so. And this can be looked into by having digital sound monitoring meters which are available, and the NICU team should be sensitized to this entire scenario. There should be a cultural change in the method of working to speak in lower voices near the baby and maintain this. Lux, sound light monitors are also available which you can use in your NICU, and anything between 10 to 600 lux is permitted at the baby area, and for procedures you can go up to 1500 to 2000 lux. This is in brief, but there is much to it than this, and a cultural change in the controlling of modulation of voice and behavior towards the baby is a very important